Bun găsit la emisiunea Știință și Cunoaștere. În următoarele episoade ale unei noi miniserii ne vom ocupa de cele mai devastatoare boli ale secolului 21 cu ajutorul invitatului special, profesorul Michael Fossel, care a acceptat să înregistrăm un nou interviu, având un rol de educare și informare a celor care suntem nespecialiști cu privire la cele 4 maladii deosebit de grave asociate cu îmbătrânirea, și anume accidentul vascular cerebral, Alzheimer, Parkinson și ateroscleroza. Vă reamintesc pe scurt faptul că Michael B. Fossel este profesor de medicină clinică la Universitatea de Stat Michigan și este autorul mai multor cărți despre îmbătrânire. A urmat masteratul la Stanford Medical School, după care a câștigat un titlu de doctor B.A. cum laude și a făcut încă un masterat în psihologie la Universitatea Wesleyan, urmat apoi de un doctorat în neurobiologie la Universitatea Stanford. El este de asemenea absolvent al Academiei Phillips Exeter. Înainte de a absolvi școala medicală în 1981, a primit o bursă de studii la National Science Foundation, Fundația Națională de Știință, și apoi a predat la Universitatea Stanford. Pe lângă postul de profesor universitar ocupat la Universitatea de Stat Michigan, Michael Fossel a ținut conferințe la Institutul National pentru Sănătate, Institutul Smithsonian și la diverse alte universități și institute din diferite părți ale lumii. În prima parte a acestei miniserii vom discuta despre accidentul vascular cerebral. Am citit numeroase statistici pe internet, dintre care unele indică faptul că accidentul vascular cerebral este identificat la cel puțin 60.000 de pacienți în fiecare an în România, ceea ce procentual ne situează printre primele locuri din Europa. Boala Alzheimer este asociată unui număr amețitor de 300 sau chiar 500.000 de pacienți, Parkinson la peste 70.000 de pacienți, arterioscleroza probabil tot atât. Având în vedere că profesorul Michael Fossel lucrează de peste 30 de ani pentru a descoperi tratamentul acestor boli și simultan combaterea efectelor îmbătrânirii, mi-am dat seama că trebuie să aibă o cunoaștere excepțional de aprofundată asupra acestor 4 grupe mari de boli, care sunt în prezent și pe drept cuvânt considerate a fi cele mai devastatoare boli ale secolului 21. În episodul de azi vom vorbi despre accidentul vascular cerebral pentru a vă oferi răspunsuri la cele mai importante întrebări. Ce este accidentul vascular cerebral? Ce înseamnă accident vascular cerebral minor, respectiv major, și cum se manifestă? Care sunt principalele simptome în situația unui accident vascular cerebral minor, respectiv unul major? Cum poate un om obișnuit care nu cunoaște nimic despre neurologie să știe dacă simptomele pe care le resimte conturează un accident vascular cerebral minor sau nu? De exemplu, el are o durere de cap, așa ca multe altele pe care le-a mai avut zeci de ani înainte, și ar putea să nu difere prea mult de ceea ce este specific accidentului vascular cerebral. Ce diferență este între accidentul vascular cerebral de tip hemoragic și cel ischemic? Cât de repede ar putea avea nevoie pacientul de ajutor în cazul unui accident vascular cerebral, în așa fel încât intervenția medicală să îi poată reversa cât mai mult din efectele secundare? Despre toate acestea și multe altele vom discuta în minutele următoare. Dear Professor Michael Fossel, welcome to our TV program Science and Knowledge in Romania for the third time.
Mulțumesc. Thank you.
Mulțumesc și eu, este o onoare pentru mine. I have not enough words to greatly thank you for recording this new interview of a long-term series of interviews many years from now on.
Well, it's a pleasure to be here with you again, Christian.
In this series, I'd like to extend our talks into the age-related diseases area, and there are 4 categories. First, let me explain the bad news. According to statistics, in Romania we have the following data. Stroke. Romania is among top in percentage of this disease. We have 60,000 strokes per year, every year, out of 20 million population. Alzheimer disease. Romania is also on top with 700,000 patients out of 20 million population. And Parkinson is on top with 70,000 patients, and also atherosclerosis is on top. I do not have a number. Can you tell us what is the situation in your country?
Very much the same. In fact, globally, it's pretty much equivalent everywhere. There are some actual health differences, and there are also some differences in the way different countries diagnose Alzheimer's and strokes and so forth. But in general, human beings are human beings everywhere. And the older we get, the more we see all of these diseases.
So, this is very scaring because the numbers are very high in percentage.
Yes, and they'll tend to get higher as we are healthy enough to get older. For example, if I were just looking at Alzheimer's disease, I would say that every one of us would get Alzheimer's disease if we lived long enough and didn't die of something else. But the same could be said for strokes, cancer, osteoarthritis. All of the diseases of aging are pretty much uniform, and if any of us live long enough, we will get anything that's coming our way.
And there is more than that in Romania. Mitochondrial factors in pathogenesis of various diseases. We have an unprecedented number of cases with multiple sclerosis, adrenoleukodystrophy, and other demyelinating diseases. So Romania has a very sick population, not to mention the 7 millions of people having chronic back pains due to disc problems, and there is no known cure. How is the situation in your country?
Well, again, it's very much the same. As I say, human beings are human beings everywhere, whether it's in Romania, Tasmania, China, the US. It's still human nature, human genes. I think that in some sense, we are lucky in that we live long enough to get these diseases. You know, if we went back centuries ago, we tended to die of gastroenteritis at age 4 and perinatal disease and so forth. We've gone beyond much of that, and we've lived longer, but the consequence of that is that we're all seeing age-related diseases. And in addition, there are other diseases that have probably become more common, and we wonder about the causes of some of these things. Part of modern life may be an exposure to toxins, not clear. But age-related diseases, as I say, are universal. It's a disaster in the US, and it's a disaster in Romania and elsewhere in the EU and elsewhere in the world. In fact, you know, the current estimates are that if we go through about another 50 years, most healthcare systems worldwide will be broke, will be out of money simply because of trying to treat age-related diseases. On the other hand, that same prediction was made about polio in the mid-20th century, around 1950, and the cost of polio now are low. I think we can actually cure many of these age-related diseases, and the fear we have about the cost of these diseases is reasonable now. The cost both financially and in human terms. But again, I think we can actually prevent and cure most of these diseases if we're a little intelligent about what we do now.
Let us begin with stroke. What is a stroke?
Well, there are two kinds of cerebral stroke, but in a very real sense for most of us, it's the same thing. In either case, you're looking at a problem within the blood vessels. Either you're looking at a clot in the vessels or the vessel has broken and is bleeding. And there are differences in how we would treat those. But in all cases, what you're looking at is aging of the arteries. And the underlying cause, whether it's the clot or the rupture of the vessel, has to do with aging of arteries. And the outcome is dead neurons, and to us that means not being able to talk or walk or think carefully. So,
what could be the most important causes of the stroke, in your opinion?
Well, of all of these diseases, and that includes things like myocardial infarctions, that is heart attacks, and peripheral vascular disease, congestive heart failure, all of these can be traced back to changes that occur in the cells that line the arteries. These are called endothelial cells. And the earliest changes, the earliest pathology that we see occurs in these cells, and it triggers a whole host of changes. It triggers increased clotting, it triggers inflammation, cholesterol deposits, aneurysms, and so forth. It results in things like strokes and heart attacks. But the earliest change occurs in the cells that line these vessels, and it's a change in the pattern of gene expression, one that we can now reset in the lab.
If a person experiences a stroke, how could one be aware of it and not confusing with an ordinary headache or cold or just not paying attention at all? What could be the main symptoms?
Well, in the earliest phases, that's exactly the problem. You know, there are people who have strokes and start off with a heart attack and simply assume it's start off with a headache and simply assume it's a headache. And the same thing is true about confusion and other symptoms. I think all of us have, for example, woken up in the morning with numbness in one arm because we slept on it, and it goes away in a matter of seconds or minutes, and we don't think of that as a stroke. But all of these things that happen to people in strokes, at the minimal amount and in the earliest phases, can be confused with lots of things. So early on, there may be no easy way to determine which it is. Is it a stroke? Is it simply a bad headache, and so forth? But two things. One is that it doesn't resolve. The strokes tend to get worse and worse. And two is, in the worst cases, there's probably very little you can do. Obviously, if you think it's a stroke, what you need to do is get medical help. And a certain number of strokes can be actually treated these days. We can, for example, dissolve some clots. Not always, not predictably, but fairly well. So I think it behooves all of us to, if we're afraid of a stroke, to go seek medical care. Still, early on, it's not so easy, and in many cases, it doesn't make a difference to the long-term outcome. Sometimes it does.
Now we are going into details. Please tell us, what is hemorrhagic stroke?
Yeah, we sometimes distinguish two types of stroke: a hemorrhagic stroke and the embolic stroke. And the embolic stroke is like having a cork in your blood vessel, and it prevents further flow of blood. Even though the blood vessel is fine, there's a cork in it. There's a clot. The other kind is the hemorrhagic stroke, and that's the kind where the blood's flowing perfectly well through the vessel, but the vessel wall has opened, and now you've got bleeding outside of the vessel, for example, in the brain. So in a hemorrhagic stroke, the blood exits the blood vessel, goes into the brain, and it does two things. One is it prevents some of the flow, because now it's in an area where it's pressing on the actual vessel. But two is it has an inflammatory and an irritant effect on the neurons themselves. So in consequence, for a number of reasons, the neurons stop functioning, die, and you're left with parts of the brain that don't work.
And what about the ischemic stroke?
The ischemic stroke is what I was talking about as embolic stroke. Ischemic is a perfectly good word for it. It just means that there's no blood going distally to the blood vessel. So if my arm were a blood vessel and I have all sorts of little arteries coming off of it, if I get a big embolus or a clot coming down here and it blocks right at my hand and all the fingers don't get blood vessels, don't get blood through them, that would be an ischemic stroke. So if this were a main artery coming into my brain and I blocked it here ischemically, these are the ischemic areas distally to the clot.
What is an aneurysm?
An aneurysm is when, again, they've got a blood vessel and the wall of it balloons out. Most people these days haven't seen the old-fashioned tires with inner tubes, but it used to be a good example. A lot of old cars had inner tubes and then the outer part. And if the outer part began to get old, the inner tube would sometimes balloon outward. And we sometimes see this in aneurysms where the wall of the vessel has gotten weak and the blood will exit the inner wall and come between the inner and outer wall, and it effectively shuts down the flow beyond that. So you can get an aneurysm that way, where the blood vessel itself is stretched out or stretched inward, and either way you get a disruption of blood flow. And in the worst case, you can actually have a rupture of the aneurysm. So where the blood wall has gotten weak and the blood has exited the inner wall and is now between the inner and outer wall, then the outer wall gives way and suddenly you have blood everywhere. So if I have my heart here and I have my major aorta coming up and an arch here, that arch is sometimes under a great deal of stress. And if I get an aortic arch aneurysm and it bursts, obviously all the blood coming from my heart doesn't go down the aorta anymore, it goes into the whole thorax, and I would be dead. So aneurysms can be very minor, very small, or they can be very major.
What is atrial fibrillation, and could this be related to stroke?
Yes. Atrial fibrillation is a condition in which the upper part of the heart, the two chambers at the top, the atria, actually, instead of pumping, they begin to sort of flutter. It's called fibrillation. I shouldn't call it flutter because it's a separate issue, but atrial fibrillation is where the atria are not beating normally. They're just having little waves like this suddenly. Now that has a number of consequences. In one consequence is that it doesn't help push the blood into the ventricle so that your pumping efficiency goes down. But the other problem is it makes it much more likely that you'll end up with a clot in the atria or in the valves between the atria and the ventricle. Because the atria is not pumping normally, the blood has a different chance or an increased chance of clotting. And that in itself wouldn't be so bad, but sometimes those clots get loose. And if those clots can get loose and end up going out into the peripheral circulation, they can cause, for example, an ischemic stroke. So if I have the atrium, if my left atrium were in atrial fibrillation and the ventricle ends up passing that clot up through the aorta, up through my carotid arteries, and into my brain, I would have an ischemic stroke that started because of atrial fibrillation.
How quick the patient would require help in case of a stroke, and how the disease evolves if he cannot get that help in a reasonable amount of time?
Well, let me say again, there are these two kinds of stroke. You talked about ischemic stroke versus hemorrhagic stroke. And with a hemorrhagic stroke, there is very little that we can do. With an ischemic stroke, what we can try to do is go in and dissolve the clot that caused the problem. Now, there are two problems with that. The first is that sometimes we don't know how long it's been. So, for example, patients will often wake up with the inability to talk or move their leg or arm. And even if we know that it was an ischemic stroke, we don't know whether that happened 5 minutes before they woke up or whether that happened 8 hours before they woke up. And there's a window of time, and it's gotten broader. We used to think it was a matter of just an hour or two, and we had to make the diagnosis and try to dissolve the clot. Well, it's apparent that the window is a little longer than that, but there's still some dispute about how long we can make that window. But the other problem besides diagnosing it is what we use to dissolve the clot causes increased risk of bleeding. So you're sort of between a rock and a hard place. On the one hand, if you don't dissolve the clot, you can end up with a permanent stroke. On the other hand, if you take the risk of dissolving the clot, you increase the risk of bleeding, that is, having a hemorrhagic stroke, in which case you can't do anything anyway. So it's always a delicate sort of a matter for us in medicine. We have gotten better and better at using these, quote, clot buster drugs to dissolve the ischemic clot that causes strokes. And we've gotten better and better at diagnosing them. But it's always a bit of a risk. So the quick answer is, the sooner the better. You'd like to know as soon as absolutely possible that somebody has an ischemic stroke. But the number of hours between the onset of the stroke and a treatment, that dividing line is increasing over the past 10 years as we've gotten to take a little more risk and be a little better at doing this.
In Romania, for example, the time which passes after a patient dials 911 for his emergency until the paramedics car arrives at his place is maybe half an hour, 1 hour.
And even then, both in Romania and the US, it depends where you live. If you're in a major city, that time is probably relatively small, but if you're out in the countryside, that time can be longer, and it depends where in the city and where in the country you are. And that's, again, true worldwide. People vary in their response times. The 911 numbers, the ambulance numbers, vary in response times from country to country, from city to country, from a number of factors. Let me also say that, though, back to with ischemic strokes, there clearly are limits. You really can't get any return if you're waiting a matter of days, for example. The damage is done, the neurons are dead. But still, that response time matters a great deal. The faster the better, and as you suggest, delays themselves can cause lives.
What are the side effects or damages which might appear in the body shortly after a stroke, and can they be reversed or at least stopped?
Well, the major damages that I think of when I think of stroke are neurologic damages. And typically it'll be an inability to speak, or in certain cases, an inability to understand language or written language even. But the more common ones are inability to speak and inability to move an arm or leg. And typically it's one-sided for the arm or leg. And with speech, it's simply, you could have a facial paralysis, but sometimes even though the face moves perfectly well, there's still that inability to speak. So those are typical sort of damages that are long-term. Now, classically, the teaching has been that once you've killed off those neurons, there's nothing you can do. Well, that's not true in two senses. One is, we know that there's a certain amount of return that occurs in the first few months. There's a certain plasticity to the brain. It relearns how to do some things, even though there's actual damage. So over a matter of weeks to months, sometimes as long as 6 months, and again, you find all sorts of interesting stories further than that even. But over a matter of months, people get slightly better often, but there's a limit. And if they haven't improved within that limited amount of time, then that's probably permanent damage. Again, typically anything you haven't seen improved over a matter of, say, 6 months, you're not going to see returns on. But there are exceptions. Now, the other interesting case, though, is not that, the matter of rehabilitation and plasticity of the brain, but is the question of what we could do with, for example, stem cells or with telomerase, where what we're doing is resetting the brain's ability to regrow neurons. We know, for example, that we could put in stem cells, and the question is, can those stem cells regrow neural connections and bring back your ability to move or speak? Interesting question. The same can be said for telomerase therapies. We know that when we turn on telomerase, we increase the rate of stem cell production and differentiation within the brain. But what does that really buy us in terms of human outcome? Does that really potentially bring back the ability to speak or move? We don't know yet.
If one patient already experienced hemorrhagic stroke in the past, is it possible to predict when will experience the next hemorrhagic or ischemic stroke?
Well, the implication is absolutely right. If you ask me what is the single major predictor for a hemorrhagic stroke, I have 1 million patients and I'm trying to predict which one of those patients will get hemorrhagic stroke. It isn't family history and clotting disorders and age, all of which are predictive, but the single major predictor is a history of prior stroke. That is, if you've had one prior stroke or even a temporary ischemic event, a temporary stroke, that increases your risk of having another one. And you know, the risk is there sort of for your lifetime, but the sooner after those events, the sooner it is after the initial event, the higher the risk. So if I had a stroke or a temporary ischemic attack a month ago, I'm at a higher risk now than I might be in 10 years. But no matter what happens, I'm at a higher risk than somebody who's never had such an event.
Could a patient experience both kinds of strokes, but in different time frames?
Yes. Now here, I assume you're talking about ischemic stroke and hemorrhagic stroke. The answer is yes. And the reason is, there are probably numerous reasons, but one of the major reasons is that both of these events are linked at an underlying level to the aging of the inside cells of the artery. So for a number of reasons, and it gets very complex, both of those events have an increased risk. If you've had an increased risk, if you have had a hemorrhagic stroke, you have an increased risk of ischemic stroke. If you've had an ischemic stroke, you also have an increased risk of hemorrhagic stroke. On the other hand, people who've had a hemorrhagic stroke are their biggest risk is another hemorrhagic stroke. People who've had an ischemic stroke, their biggest risk is another ischemic stroke. But still, both are somewhat linked.
What is transitorial ischemic stroke and what is happening in this case in the brain?
Transient ischemic attack or a transient hemorrhagic stroke?
Transient, yes.
Okay. In English, we call it a TIA, or transient ischemic attack, or a transient ischemic event. And what it means is you had symptoms of a stroke, but they went away. So perhaps I woke up in the morning and I found that I couldn't move my left arm and I had what seemed to be a stroke, and yet a few hours later, even without treatment, it's gone. That would be a transient ischemic attack. And having had one of those, it increases your risk for having another one of those, and it also increases your risk of a permanent stroke. Well, what it is, probably, in most cases, is probably you had a small clot that was lodged in a vessel and was interfering with blood flow, but it either dissolved or it moved peripherally to an area that was a little less critical. But probably these strokes occasionally dissolve. These clots. You and I have had clots as we've talked right now. We have clots all throughout our bodies. Little ones, usually very little ones, but sometimes bigger ones too. And most clots are not, they don't cause fatality. They may not even cause any discomfort or loss of function, as long as they're dissolved in time, and it depends where in the body they are. You know, if I've got a small clot in my finger that dissolves, I'm not likely to have much of a problem. If I have a small clot in the brain and it's in a critical area that controls my breathing, I could have a large problem. So it depends where it is, how large it is, and how fast it dissolves.
What is vasculitis? And what is the phenomenon taking place in this case?
Well, vasculitis is like saying, it's a big category. And there are many things inside it. It's as though I were to say infectious disease. Well, there are lots of infectious diseases. If I were to say vasculitis, it can encompass lots of things. What it means is an inflammation of the vessel wall. So if I have an arterial vasculitis, it means the artery itself has inflammation on the wall itself, but there are many kinds. You could have due to an infectious process, you could have it due to an autoimmune disease, you could have it due to some sort of trauma that initiated some of these problems, like an inflammatory reaction. But the outcome is, again, encompasses a lot of things. It could cause a permanent problem. For example, there are some vasculitis diseases that I can get here in the arteries around my face that can cause long-term problems. If I have it in my brain, I could certainly get a long-term problem, a stroke, for example. So it depends where in the body it is. And likewise, the treatment for these things depends. If I know it's totally inflammatory, I might treat it with steroids. If I knew it was strictly a matter of infection, I might be able to find an antibiotic that would be appropriate for that infection. So it encompasses many things, many causes, many symptoms, and many treatments. Depends on which one you're looking at.
Please talk about the connection between atherosclerosis and stroke.
In all cases, stroke, atherosclerosis, all the arterial diseases of aging, they're all linked at an underlying level to these changes in the cells that line the blood vessel, the endothelial cells, and changes in gene expression within those cells. So if I'm looking for atherosclerosis, classically I would define that as if this is the cell that lines the vessel wall, just between that inner cell and the layer right outside it, you begin to get inflammation, you begin to get macrophages, you begin to get laying down of cholesterol plaque, and all of these things. There's a good example. You've got a tube there, and the innermost cells are the endothelial cells, the outermost cells are the wall of the vessel, but right between those, there's a potential layer. It's called the subendothelial layer. And in that, you begin to get the inflammatory cells, you begin to get all sorts of cytokines, you begin to get laying down of cholesterol plaque, you begin to get disruption of the cell adhesion through there. Now, the outcome that we see under a microscope are cholesterol plaques, for example, atheromas. So that classically would be your arteriosclerosis or your atheromatous disease. But the consequence for that, for strokes, are sort of two things. One is, if I have that sort of disease occurring in a blood vessel, I'm weakening the blood vessel wall, so I could have a hemorrhagic stroke. I'm also infringing on the inner space within that vessel, so I'm beginning to make it narrow, so I'm getting less blood to the brain. But I also, the cholesterol plaques and the atheromas that form in these vessels can be torn loose. So you've got a clot that comes downstream. Also, the clotting mechanism is triggered on the walls of these. So I begin to get clots just in this wall, let alone the whole atheroma going downstream. The outcome is that whenever I get an atherosclerotic disease, I increase the risk of anything happening downstream. Increase clots, increase emboli, thrombi. I can increase the risk of simply constricting the vessel, as happens often with the coronary arteries. So any number of diseases can occur downstream as a result of these age-related changes in the blood vessel in the artery itself.
What is the real physiopathology of atherosclerosis in the light of your 40 years of research, the one you understood, not the one from the old medical books?
Right. Well, again, prefacing this by saying, whenever you talk about the real cause, you're sort of missing the point, because there are thousands of causes upstream, downstream, and every other which way. And I like to focus on, okay, but where do we step in and fix it? But allowing for that, I'd say that the cause, looking at it simplistically from my point of view, the cause is cell aging of the vessels that line the arteries, and they cause changes in inflammation and cholesterol plaque and so on. And the result of that is coronary artery disease, strokes, aneurysms, congestive heart failure, peripheral vascular disease, all of the things that we think of as clinical disease. But again, in simplistic terms, it all comes back to changes in gene expression in the cells that line the vessels. Back to my practical question, my concrete question, that's nice, but what do we do about it? The answer is the same, which is the single best point of intervention is not controlling your blood pressure, controlling your cholesterol, controlling your diabetes, No, the single best point of intervention is to reset telomere links in those endothelial cells. Should work like a charm. works nicely in cells, tissues, and animals.
What would be the best treatments for atherosclerosis, and how much diet and lifestyle might help?
I'd say the same answer. You know, in 1950, if you said to me, how do we prevent polio? In 1950, the answer was, you know, you stay out of public places and you do what you can. There were even books about diet for polio. Seriously, bestsellers. And yet in 1954, the vaccine got released. And if you ask me how to prevent polio, the answer is pretty clear. Vaccine, not diet, public place. No, but that's kind of where we are now with regard to all these arterial diseases. Right now, if you really want to do something, the answer is the same thing your doctor and everybody else tells you. It's cholesterol and high blood pressure and diabetes and smoking, etc. But I don't think that's the answer. The answer is going to be to step in and reset gene expression in the cells, trigger the entire cascade of events, and end up preventing and curing atherosclerotic disease completely. And moreover, doing it at a cost that's probably about 95% less than the cost now. In short, I think if you take all of the global costs for atherosclerotic disease, arterial disease in general, stroke, heart attack, aneurysm, peripheral vascular disease, congestion, everything, I think we can end up paying about 5% of the current costs and treating all those diseases completely. I think we can undercut the cost of global healthcare enormously and effectively too.
Are there any known genetic factors which may cause atherosclerosis?
For atherosclerotic disease? Yeah. Absolutely. Yes, tons of them. You know, again, looking at things like clotting, inflammation, high blood pressure. Some people would think of smoking as related to genetic factors, you know, behavioral challenges, weight. It just goes on and on. There are, you know, I probably could list dozens before I paused and checked the literature, and I'm sure there are hundreds of genes that are related, one way or another, to risk of heart disease.
Let's assume a patient already had a stroke, but he also had been diagnosed with diabetes. Which of these two conditions are posing a bigger threat, and what should the patient or the doctor do in the first place?
Well, luckily it's not a, you know, it's not what they call a zero-sum game. You can treat both at once, and the treatments are very different, and the risks are different in many ways. So, for example, if I have a patient who already has a stroke, if that stroke has already been dealt with, that stroke maybe happened a week ago, there is very little I can do medically to improve your chances. Now I can talk about rehabilitation, I can minimize the stress, the blood pressure, anything else, the high cholesterol levels, but I can't actually treat the stroke. Whereas diabetes is a little different. It's a much more, you know, it's a chronic condition that can be treated in a number of ways depending on what kind of diabetes you've gotten. But classically what you're doing, obviously, is controlling blood sugar levels. Now the downstream consequences of diabetes are also important. So, for example, if I have increased diabetes, I also increase my risk of atherosclerotic disease, increase my risk of increased blood pressure, renal failure, all sorts of things. So what I'm really saying is, in some ways, once you've had the stroke, if you also have diabetes, you can treat both at once. And the diabetes is the one that in many ways needs the most attention, because while there are limited things we can do for stroke, there aren't many of them, and they certainly don't conflict with treating diabetes. I guess I would have to say that diabetes is the more important one, simply because I can do something actively about it. And it's hard to do that for a stroke once it's completed.
Let's take another scenario, and the patient experienced a stroke while having oscillant blood pressure from very low to very high, and then drop again to very low, and then to very high again. Can you explain this phenomenon, and what are the precautions and the dangers this kind of patient must take into consideration?
Well, trying to explain fluctuations of blood pressure can be very hard, but let me give an analogy for the audience. Let's say I'm trying to fly over the Transylvanian Alps, and I happen to know that let's say that the average altitude of all of the Alps as I'm flying over the mountains, say that it's 4,000 meters. I have no idea. Say it was 4,000 meters. But it may range from 100 meters to 8,000 meters. May go back and forth. And what I cannot do is simply assume that if I fly over at an average altitude of 4,000 meters, I won't hit a mountain. Because that may be the average altitude, but it's not a safe altitude because some places are higher than that. But the same is true of the blood pressure. With blood pressure, your average blood pressure is not the important issue. It's somewhat important, but the critical issue is how high does it go? Because those are the mountains you'll hit as you're trying to fly over it. So blood pressure is not simply a matter of average blood pressure. As you're saying, the fluctuations are critical. If I get too high a blood pressure, I can increase my risk of having a hemorrhagic stroke or opening an aneurysm. If I get too low a blood pressure, I'm not delivering blood to the brain. So both of the extremes can be deadly. Reminds me actually of diabetes. You can die from too high a blood sugar or too low a blood sugar. The same is true of hypertension and hypotension. The problem is, as you've said, sometimes you'll get patients where these things will fluctuate. And the causes of that fluctuation are part of the issue. If it's caused by neural changes, it can be extraordinarily difficult to get a hold of because I can't change the way the brainstem is manipulating my blood pressure. If it's a more peripheral issue, then perhaps I can. For example, if it's changes in electrolytes, or it's an infection, or it's stress, and all of these things together, those are things that are a little easier to address for a physician in the intensive care unit, for example. In any case, you do need to get hold of both fluctuations. Too high or too low are both deadly.
Are there any known genetic factors which may cause stroke?
Yes, many. The classic ones are changes in your blood's ability to clot. If you clot too easily, obviously you can get increased clots or emboli in the blood vessels. But if you clot too poorly, you bleed too easily, then you increase your risk of hemorrhagic stroke. In the same sense that I said all of us have little clots all throughout our bodies daily, and that we usually deal with them fine, all of us have little bleeds throughout our body as well, some of us more than others. If I hit myself like that, I'm not going to bruise, but some people do. And the older we are, the more likely we are to bruise. That's bleeding under the skin. It's bleeding from my blood vessels. Now, most of us don't bruise that easily, but some of us do. If you bleed too easily, increased risk of hemorrhagic stroke. If you bleed too poorly, increased risk of thrombotic stroke or embolic stroke. So those are common genetic factors, but there are others. If I look at anything that affects, for example, your immune system, your blood pressure, your cholesterol levels, any of those things can increase or decrease, depending on what genes you have, your risk of different kinds of strokes. So there are, my guess is here, probably hundreds of genes that play a role. Of classic ones that people identify and say these are risk factors, you're probably looking at a couple of dozen. But there are probably more than that we're either not aware of or only minor risks.
But this is scaring if so many genes may cause these illnesses.
Well, it's not really cause. It's more of a correlation and an increased risk. If I take a walk from here a mile away down the highway, I increase my risk of getting hit by a car, but is my walk really the cause of getting hit? Depends how you look at it. Every time I go out in my car or drive anywhere or walk anywhere, I increase my risk, and yet that's sort of the nature of going through life. I need to have a certain amount of risk. All of these genes have different risks, and in general, you're fine. Most people don't get strokes until their 60s or 70s. There are people who get strokes in their 20s, not many. And again, it depends on their risk factors, including their genetic risk factors. But there is no specific gene that causes a stroke. There are genes that certainly increase your risk or decrease your risk. But there's no gene that just automatically causes a stroke. Just a matter of increased risk, decreased risk.
My mother experienced an ischemic stroke 3 years ago, and this affected the acoustic nerve, and she remained without hearing on one of the ears. But she had difficulties in adapting walking. Why walking is related with hearing?
I assume then it didn't affect the vestibular nerve, which would have affected her balance. Because you're right, hearing itself is one of those cues we use as we walk along. But more commonly, vestibular function, which is also starts in the ear in the vestibular canal, will affect walking. So I don't know which it was.
Now she's walking okay, but in the beginning had difficulties because she perceives sounds only with one ear.
I'm sorry about that.
She is now 80 years old. Please tell us what other complications might appear after a patient suffers more than one stroke.
Well, anything at all. Because you can have a stroke anywhere in your brain. There are certain areas that are more prone to strokes than others, but anything can happen. Anything that the brain does can be affected. So that could be memory, thinking, recognition, speech, hearing, ability to write, ability to comprehend words, ability to say things that are comprehensible, ability to move your arms, to move your legs, even the ability, of course, to have a normal heart rate or breathing. All of these things can be affected. So any number of things, anything.
Is vascular ultrasonography helpful for medical diagnosis?
Yes, it is, as are a number of other diagnostic modalities these days. What you're asking really is, can I get a good look at the blood vessels and see whether there is some disruption or increased narrowing of the blood vessel so I could treat it. Example, if I could do a carotid ultrasound here and show that I had narrowing of that because of atherosclerotic disease, then the question comes up, should I go to surgery to try to bypass or stent or remove the clot, all of which have been tried over the years, and decrease my risk of stroke? Then the question, of course, is, am I going to have a stroke during the surgery because of doing things to my carotid artery? How good is the surgeon? How advanced are the technologies? How good are we at diagnosing it in the first place? But that's the kind of question that you get with an ultrasonography looking at carotid arteries, for example, or if I'm using advanced MRI techniques or other techniques to look at vessels, same question. Can I effectively diagnose a narrowing or otherwise pathology of the vessel in such a way that we can take it to treatment? Now, there are some vessels that are essentially impossible to treat because of where they're located. But in general, if I can diagnose it, it's a reasonable question to ask if I can go in and treat it or not. It doesn't mean the treatment will be effective, but the question is worth asking.
What kind of other medical technology exists on the present moment in order to diagnose or treat stroke disease?
I don't know, Christian. I haven't followed this particularly over the past year or so when I've been focused on Alzheimer's. For the diagnosis of stroke itself, you're looking at two sorts of things. One is making a diagnosis ahead of time of your risk. For example, as you said, looking at the ultrasound of my carotid arteries as an example. But the other question is, can I diagnose what's happened during the stroke? And here you're looking at things like MRI scans or CAT scans, but also now there are more advanced techniques looking at things like targeted PET scans, where I'm actually looking at the metabolic changes that occur in neurons and glial cells throughout the brain. So I can actually focus in on the function of the brain itself, not just the blood vessels. So there are a lot of techniques that are going on right now, as well as additional techniques where I'm measuring blood changes. So I may be measuring some of the damage occurring to my neurons or my glial cells, or just the ischemia in general. And as a result, I see some of these changes in the blood vessels. These things are changing on a weekly or monthly basis. There are new options being offered. Not all of them will work out. Some of them are maybe work out very well, but are not quite accepted as mainstream yet. But things are changing rapidly. We're getting better and better at making diagnosis both ahead of time and once you've had a stroke, understanding exactly what's happened.
What would be the hope for cure and prevent stroke in the near future within the light of your research at Telosite?
Well, what we're focusing on is resetting the function of the cells that cause the disease in the first place. So, as an example, in Alzheimer's, we're looking at the glial cells within the brain so that we can fix and prevent problems, both to the neurons. But if I'm looking at stroke, as I say, all of the major kinds of stroke that occur start with a blood vessel. And what we are doing in that case is we'll be showing that we can actually reset the pattern of gene expression of those cells. So we're taking cells that are not functional and we're making them act more like 20 or 30-year-old cells rather than 60 or 70-year-old cells. Now, the outcome for that is that we can, I think, almost certainly prevent and certainly lower the risk of most strokes. So, for example, if I know that you've got a high risk for stroke in the next 20 years, I can lower that risk to what it would have been, say, at age 20 or 30. On the other hand, the question comes up, what if you've had that stroke and now you've lost a piece of the brain, for example, the part of my brain that lets me speak over here. If that happened, then can I get that back? Well, there must be limits, and I know that. I sometimes think of them as Humpty Dumpty phenomena. There's the old children's nursery rhyme of the egg that falls off the wall, and neither all the king's horses nor all the king's men can put the egg together again. Some things I can't put together again. You know, if I've got a certain number of dead neurons, there have to be limits. And yet, the animal studies suggest that, as I say, we can reset the ability of the brain to have neural stem cells to replace some of the dead neurons. And we know that it occurs. It does replace dead neurons. But the question is how much, and are they as functional as you'd like them to be? So maybe I can replace some of the neurons in my Broca's area that are responsible for my speech, but will I be able to speak, or will I have to learn it all over again? Will I ever be able to learn it all over again? We don't know what those limits are, but they certainly are. I think we can be more optimistic than we would have been a few years ago. We just don't know how far we can take this.
In 2016, I saw a movie called Brain on Fire, and is about anti-NMDA receptor autoimmune encephalitis. Susanna Caherlan's book and story helps thousands of patients to be correctly diagnosed. Please explain what is autoimmune encephalitis and why it's so difficult to correctly diagnose.
No, I would have a hard time answering that question, Christian. I think it's mostly outside of my understanding. The autoimmune obviously means that your immune system is responding to something that it shouldn't to. So, for example, if I have a perfectly normal protein that's part of my makeup and I develop an immune reaction to that protein, that's an autoimmune disease, as opposed to having a virus come in and I develop an immune reaction to the virus. That's normal. But autoimmune, I'm essentially allergic to myself. Now, the problem in autoimmune encephalitis or in autoimmune arterial disease causing neural damage is that your body is responding again to proteins and other molecules, for example, glycoproteins and so on, that it shouldn't. And if that happens in the blood vessel, what you're going to get is you're going to get an inflammatory reaction, an arterial disease, and consequently increased risk of stroke, for example. If it happens within the brain, for example, in autoimmune encephalitis, you could actually develop an allergy to your brain. That's been done both experimentally, and we see it in real patients, not experimentally, but just clinically. And the outcome in there, again, can be a disaster, every bit at least as bad as a stroke. But the treatment for it, when there are any, is very different, because what you're trying to do is modulate, you're trying to control the immune response, and that can be very delicate, in the same sense that you don't want too high a blood pressure or too low a blood pressure, or too much clotting or too little clotting. You don't want an immune system that is overreactive or underreactive. And trying to get that balance just right so that my body still responds to, for example, bacteria and fungal infections and viral infections, but does not attack my own body, it's delicate. It's easy to shut down the immune system, in which case it's a disaster because you'll die of infection. And in the same sense, you could do nothing, but then you've got the autoimmune encephalitis. So these things are not easy. And I think that people are getting better at this, but again, it's outside my purview.
Yes, the movie was bringing hope for all the people who were wrongly diagnosed over the time, because the symptoms they presented were very similar or almost identical to those of other diseases which had required other kind of medication or treatments. For example, seizures like those of epilepsy or schizophrenia or other similar neurological diseases. But in reality, the real cause was the immune system is fighting against the brain. And this is where the titles of the movie and book came from, Brain on Fire. And only one Arabian doctor had solved the mystery, and after publishing the book and making the movie, many other similar cases were inspired by the book and the movie, and now they are treated correctly.
You know, Christian, I think the one thing that you can guarantee about medicine, as with most human life, is that if you go forward a generation or two, we will look back and think we were fools. We often look back medically and can't figure out why we didn't know something 20 years ago or 50 years ago or 100 years ago. And for example, if you look back 200 years, people were commonly bleeding other people for diseases. So you let out blood. And we look back and think that was foolish. And we look back 100 years ago, and I see some of the recommendations for diet that we look back on and think were foolish. For example, there was a recommendation that sugar was nature's perfect food. We should eat nothing but sugar. To us, that looks stupid. But I guarantee you, if we go forward 100 years, people will look back at what we're doing now and not believe we were so blind and narrow-minded. So I always take that with a grain of salt. So I'm glad to see in advance, and I just wonder what else we're still missing. I'm sure we are.
Thank you very much for part 1, and let's meet next time for part 2 about Alzheimer's disease in our Science and Knowledge TV program on TVR Cluj, Romania. And I thank you very much for this opportunity. Michael Fossel a fost membru activ în conducerea Consiliului de Administrație al Asociației Aging American, ocupând funcția de director executiv. El este fondatorul și fost redactor șef al revistei de medicină Anti-Aging, cunoscut acum sub numele de cercetare a întineririi. În cartea sa Revoluția telomerazei, autorul Michael Fossel afirmă următoarele: suntem la un pas de a face un salt imens înainte și vom deveni capabili să reversăm procesul de îmbătrânire într-un mod evident și izbitor. Suntem pe cale de a vindeca și nu doar de a preveni maladiile legate de îmbătrânire, dar mai mult putem reseta procesul de îmbătrânire ca atare. Am încheiat citatul. La pagina 171 din cartea lui Michael Fossel, numită Revoluția telomerazei, există un citat din Molière care spune, citez, mai mulți oameni mor din cauza remediilor decât a bolilor. I-am pus profesorului Fossel o întrebare legată de encefalita autoimună. Ei bine, aș mai preciza câteva completări, și anume, cartea și filmul Brain on Fire dezvăluie problemele lui Susanna Cahalan cu encefalită autoimună de tip anti-NMDA receptor și procesul prin care a fost diagnosticată cu această formă de encefalită. Se trezește într-un spital fără memoria evenimentelor din luna precedentă, timp în care ar avea episoade violente și iluzii. Diagnosticul ei este îngreunat de diferiți medici care au o părere greșită, cu câteva teorii, cum ar fi petreceri prea dese și tulburare schizoafectivă. În cele din urmă, mai mulți medici, inclusiv dr. Souhel Najjar, au început să suspecteze că Cahalan suferea de o boală autoimună. Dr. Najjar a diagnosticat-o pe Cahalan folosind un test care implica desenarea unui ceas, un test administrat în mod obișnuit persoanelor suspectate de demență sau boală Alzheimer. În loc să deseneze în mod normal fața ceasului, boala a făcut ca Cahalan să deseneze toate cifrele de la 1 la 12 doar pe partea dreaptă a ceasului, deoarece partea dreaptă a creierului, care reglează partea stângă a corpului, a fost inflamată. Najjar a folosit acest lucru pentru a ajuta la diagnosticarea lui Cahalan și ea a început drumul spre recuperare. Cartea ei include de asemenea viața personală de după recuperare, inclusiv reacțiile la vizionarea de casete video ale episoadelor psihotice din spital. Cahalan discută de asemenea simptomele ei înainte de spitalizare, deoarece a fost diagnosticată anterior de către un psihiatru cu tulburare bipolară. În timp ce studia atent, Cahalan a aflat că boala este recent recunoscută și că a fost descoperită oficial doar cu 3 ani înainte de a se îmbolnăvi. Iar cercetarea ei a indicat că în anul 2009 majoritatea persoanelor cu această boală au fost fie diagnosticate greșit, fie nediagnosticate. Cahalan a avut norocul de a fi corect diagnosticată, deoarece, potrivit estimărilor doctorului Najjar, doar 10% dintre bolnavi au fost diagnosticați corespunzător la acel moment. De atunci există în lume o mai bună înțelegere a bolii și a simptomelor sale. Data viitoare vom continua discuțiile pe teme importante legate de bolile asociate cu îmbătrânirea, precum Alzheimer, Arterioscleroza, Parkinson și alte maladii degenerative. Vom analiza mituri și veți afla peste cât timp va fi disponibilă o terapie a tuturor acestor boli. Știința este o aventură nesfârșită la marginea incertitudinii. Fiți alături de noi data viitoare la o nouă întâlnire cu știință și cunoaștere.